Good morning, everyone. My name is John Reynolds, and my co-chair is Will Robb, and it's our great pleasure to chair this upper GI surgery session at the Charter Day 2022 meeting. Just to remind you that if you have questions, to post them in the Q&A section, please, and Will and myself will get to those after each of the presentation. We have a really excellent program. First, with really a masterclass on GERD from Marco Patti, and then we've selected some hot topics in relation to upper GI surgery to present and discuss. So, without further ado, we'll get started, and it's my great pleasure to introduce Marco Patti to you. He was born, reared, and educated in Catania in beautiful Sicily, and was mentored by some of the greats in upper GI surgery in San Francisco, and Carlos Pellegrini and Lawrence Way, and in Hong Kong with Professor John Wong, and then went on to have faculty and chair positions in San Francisco first, and then on to University of Chicago, where he directed the Center for Esophageal Disease, and from 2016 to the University of North Carolina in Chapel Hill. And it's really true, and not an overstatement, that Dr. Patti is the doyen of upper GI surgery for motility disorders, including achalasia, and certainly also a leading light with respect to the approaches to gastroesophageal reflux disease and esophageal parasophageal hernias and such like. And he's been invited all over the world, and incredibly, this is his first visit to Ireland, and you are so welcome to the college and to Dublin and to Ireland, and we really look forward to your talk, Marco. Thank you.
Just a second, we are organizing it. Can you see my slides? Hello?
Yes.
Oh, perfect.
Perfect.
So let me start by thanking Professor Reynolds for this wonderful invitation. Indeed, it's my first time in Ireland, and especially from my mentors like Carlos Pellegrini, I always heard beautiful things about Dublin and the Royal College of Surgeons. So I was asked to discuss the evaluation and treatment of gastroesophageal reflux disease. I don't have any relationship with commercial interests regarding this presentation. So when we talk about reflux and talk to patients, we always discuss the potential of an evolution of the disease towards Barrett's esophagus with low-grade dysplasia, high-grade dysplasia, and cancer. But at the end of the day, there are only 17,000 new cases of cancer in the United States. And unfortunately, 5-year survival is only 10 to 15%. But during my career, I had a strong interest in a different aspect of gastroesophageal reflux disease. And that's basically the lung problems that are related to the disease. Even though it's called idiopathic pulmonary fibrosis, there is no question today that reflux with aspiration of gastric contents plays a big role. Interestingly, there are 40,000 new cases every year in the United States, and look, the 5-year survival without a lung transplant is only 10 to 15%. So many of these patients are asymptomatic. We do special testing, and we feel that if you block the disease at a certain level, you don't need to go to a lung transplant. But you have to be careful, because after a lung transplant, if there is reflux and aspiration, you can develop the so-called bronchiolitis obliterans syndrome and even rejection, and without another transplant, death. So I think the fundoplication has withstood the test of time. But why do some fundoplication fail? And that's what I would like to treat today. Let me start with wrong indications and the wrong preoperative workup. So we are all familiar with the indications in 2022, symptoms, reflux that doesn't respond well to PPIs, large hiatal hernias, poor patient compliance, or at least in the United States, the cost of medical therapy, and then the side effects, in addition to the classic C. diff, osteoporosis. We have cardiac arrhythmias, we have major adverse cardiac events, kidney disease, and maybe dementia. But what's really tricky is when a gastroenterologist sends you a patient for refractory reflux, meaning symptoms that are resistant to proton pump inhibitors. I think there are two types of reflux. There is true reflux. Maybe patients needs more than 2 pills a day. Maybe they have a large hiatal hernia and they don't respond well to medications. But what's dangerous is when patients are symptomatic, but they're not evaluated properly and actually don't have reflux. Well, let me share my personal experience with that problem. It was 1995. I was fresh from a fellowship with John Wong in Hong Kong. My mentor, Carlos Pellegrini, had left a very large practice at UCSF. So one of the gastroenterologists sent me this patient, 58 years old woman. She was a pretty famous CEO of one of the major companies in Silicon Valley. She had some heartburn, she had some nausea, minimal response to proton pump inhibitors, grade 1 esophagitis at the time according to the Savary-Miller classification, small hiatal hernia. Well, I never operated without manometry and pH, but sure enough, she refused any test. So the gastroenterologist reassured me and I did an operation. I did a Nissen fundoplication. The operation went well. She left after 1 day. But when she came back to follow up after 3 weeks, symptoms were the same. So we repeated all the workup. The endoscopy was normal, the barium swallow was normal, manometry and pH was normal. So what was my mistake? My mistake is I operated based on symptoms that can be common to many diseases. And then the endoscopy really showed nothing more than a grade 1. So if I had performed the proper workup, I would have never done a fundoplication in that patient. So as you can imagine, for a junior attending, that was not a good way to start. So a few years later, when I was still in San Francisco, the gastroenterologist and myself decided to do a study. We selected about 800 patients. They were sent to me for surgery based on symptoms and endoscopic findings. So we eliminated patients with Barrett's esophagus because there was a pathology diagnosis. Typical group, about 50 years of age, symptomatic for a long time. 44% were on PPIs, 23% the time there was this combination of PPIs and H2 blockers. So when we did the manometry pH monitoring, this is what we found. We found that only 70% of patients had a pathologic amount of reflux by pH monitoring. But 30% of 247, even if we repeated the test, at the time was easy, the insurance don't complain, actually they were negative. So we were able to follow up 120 of these patients, and these were the alternative diagnoses we found. Cholelititis, irritable bowel syndrome, but 18% had achalasia. So you can imagine it would have been a disaster to perform a fundoplication in somebody with achalasia. So the problem with refractory GERD and the failed fundoplication is that when gastroenterologists send us patients based on symptoms, lack of response of PPIs, we are asked to do a fundoplication. Especially in private practice in the United States, there is a lot of pressure. So we do the fundoplication, and sure enough, if the patient has symptoms not related to reflux, they will have symptoms again. So then we get a call and say, listen, you failed one time, try to do it better this time. Well, the redo is not easy, so you're lucky if you just have the same symptoms without any complications. But often there are complications, and sometimes you end up doing a resection or a Roux-en-Y. So this is my preoperative evaluation. I do a barium swallow, I do an endoscopy, manometry, and pH monitoring. In patients that have idiopathic pulmonary fibrosis, I like to do a bronchoscopy and I do bronchoalveolar lavage and test for pepsin, because if I find pepsin in the airway, I know that this patient is aspirating. Now, this is not only my workup. In 2013, there was a consensus in the States during the Digestive Disease Week. In blue, you see the names of pretty famous surgeons like Jeffrey Peters, Reginald Bell, Liz Wanstrom, Tom DeMister. In red, the esophageal experts in the United States among the gastroenterologists. As you can see, what was recommended before anti-reflux surgery was a barium swallow, upper endoscopy, manometry, pH, and in selected patients may be connective tissue disorder or long-standing diabetes on insulin, do a gastric emptying study. There is, especially in the United States, a possibility to perform the wrong operation. And unfortunately, obesity is a major problem in the United States. So you get patients that are referred to you with a BMI of 40, 45, and they have a lot of reflux. Let me remind you that in these patients, the pathophysiology of the disease is slightly different. In addition to the problem with the sphincter or peristalsis or a hernia, you have an increased thorac-abdominal gradient. So you have an increased positive pressure in the abdomen, which in the fasting state means intragastric, and you have often a more negative pressure in the chest. So the gastric contents tend to reflux into the esophagus. And this is more common in men because they tend to have central obesity. So increased abdominal pressure, more negative intrathoracic pressure. Now the teaching, and that's what we tell our residents, oh, don't worry, somebody comes with a BMI of 45, why don't you do a bypass? It's a great operation for obesity, for comorbidities, but also you have a very small pouch with very few parietal cells. You have a long Roux-en-Y loop, 100, 120 centimeters, so you will not have reflux of bile. In theory, this is perfect. But let me remind you that when we start doing laparoscopy, Roux-en-Y gastric bypass, initially it was retrocolic, retrogastric. And then Phil Shower proposed to go antecolic, antegastric, because technically it's much easier. So this slide shows what the problem is. It was sent to me by another surgeon that said, this patient still has reflux, I don't understand why. Well, if you look at this image, you know why. Instead of having a small proximal gastric pouch that you can see up there just below the gastroesophageal junction, this surgeon basically started transecting the stomach at the level of the incisura, so it looks almost like a sleeve gastrectomy, in order to have no tension on the gastrojejunal anastomosis. Well, in this incredibly long pouch, there are a ton of parietal cells, so this patient was having acid gastroesophageal reflux. So we transected the pouch much higher, and the patient eventually did better. Controversial issue is the type of fundoplication. Total fundoplication, partial posterior, partial anterior, also known as descent, toupet, and door. Well, I'm going to show many studies that have shown that the two operations, at least in Europe and Australia, are very similar in terms of results. This is a comparison of 65 open Nissen, 72 open toupet, with a very long follow-up, 18 years. Same control of symptoms. Same control studies was done with a laparoscopic Nissen and laparoscopic toupet, and again, similar control of symptoms. And then there was recently a systematic review with a meta-analysis of randomized clinical trials. They show that when you compare a Nissen to a door fundoplication, there is a similar symptom control, but a lower incidence of dysphagia, flatulence, or inability to belch. And today, JAMA Surgery actually published a study done in Sweden and Denmark that shows that at the long-term follow-up, there is no difference between a Nissen and a toupet. Let me be honest with you, I've never been able to have the same results with a partial posterior fundoplication. The results from my center at the University of California, from Carlos Pellegrini, from Liz Swanstrom, have shown that at least in the United States, maybe we do a 240 instead of 270, but about 50% of patients had pathologic reflux at 5-year follow-up. So whenever the motility is okay, I like to do a Nissen fundoplication. It's also much easier to teach. These are the classic steps. I like to do an extensive mobilization in the mediastinum. Contrary to the study in Australia, I like to take down the short gastric vessels. I don't want to have any tension. I try to have 3 to 4 centimeters of esophagus below the diaphragm. I approximate the pillars with non-absorbable sutures, leaving some space. I always use a bougie. The randomized control from Liz Swanstrom showed that there is a lower incidence of dysphagia. And then again, it's dealer choice if you do a total or a partial fundoplication. Now, I would like to show this movie. Let me stress that the operation was done by one of my fellows. So the patient had normal manometry, upright reflux limited to the lower esophagus. This is the position of the patient on the table. The surgeon operates in between the legs. Position of the ports, I think the key is to place the camera 14 centimeters distal to the xiphoid process. Whenever there is not a big hernia, we like to start by opening the gastrohepatic ligament. As you can see here, we use the monopolar current. We then start taking down peritoneum and phrenoesophageal membrane, dissecting off the right pillar of the crus. Better than what you see in this movie, is important to leave more peritoneum attached to the right pillar because it will hold the sutures better. That's the posterior vagus that you see, and you see at the bottom the junction between the left and the right pillar. We then want to transect the phrenoesophageal membrane. We use a grasper like a right angle clamp in an open case. And then we use a instrument, in this case is a bipolar instrument, to take down the short gastric vessels. Now, as you will see in this movie, the upper short gastrics were very close to the spleen. So I don't believe that you can do a good Nissen without taking them down, because I'm afraid of tension, and that's really not what I want. Then we are approaching the left pillar of the crus, still using the monopolar current. And then the idea will be to separate the left pillar from the esophagus. We use more and more the bipolar instrument, and we really want to have some esophagus without any tension below the diaphragm. We are completing the dissection, and basically we have a window, retroesophageal. At this point, we like to pass a Penrose drain around the esophagus. It's soft, so we don't get any injury by grabbing the gastroesophageal junction with a Babcock. Even though there was a small hiatal hernia, we like to do again the dissection, so we don't have to worry about the tension, and hopefully this will keep the fundoplication. Now, especially operating with fellows, I like to use this instrument for approximating the crura, because with a regular needle, there will be the risk that the posterior part of the needle can injure the esophagus. So we have completed the dissection, and now we want to pass the fundus behind the esophagus. We always do a shoeshine maneuver, because that's a key part to avoid to have redundant fundus due to the fact that we go too low on the gastroesophageal junction. In this case, we use a 56 French bougie, and then we put together the right and left flap of the fundoplication. Operating with recipients of fellows is easy to grab them with a Babcock clamp, so they can take all the time they want. We use a Tuo silk. The stitch clearly goes intragastric. and we apply 3 stitches only. In the past, we used to put coronal stitches, lateral stitches. I honestly, at this point, I don't think it made any difference. The key, as you can see here, is to have a fundoplication without any tension. And so this is completed. So there is a beautiful study that was published a long time ago from the University of Washington in Seattle, the group of Pellegrini. They look at patients that had reoperations and say, why did they fail? Well, in this case, clearly there was not enough dissection, so the G junction and the fundoplication are above the diaphragm. Even worse in this case, they left the gastroesophageal junction above the diaphragm, and the fundoplication is stomach on stomach. This is what happens if you don't do a shoe-shine maneuver. I honestly don't believe in the so-called slip Nissen. I think it's iatrogenic, it's my fault, and is even more evident in this case. You try to create a so-called floppy fundoplication. You go too low on the gastroesophageal, on the greater curvature. You do an oblique fundoplication, stomach on stomach. This is the worst, because patients will have not only heartburn, but also will develop dysphagia, because there is not the receptive relaxation of the fundus. So I think I have shown the workup we like to do, and whenever possible, again, we do a 360-degree fundoplication. Now, recently there has been a tremendous amount of pressure brought on gastroenterology and surgeons to have alternatives to the laparoscopic fundoplication. This is a manuscript that you will not find on PubMed, but is one of the best. That's, you can recognize Ulysses that comes back to Ithaca from the War of Troy and is trying to resist the sirens that are singing. Well, it's very similar in surgery. According to the industry, 70% of patients do well with PPIs. Almost nobody should have a fundoplication. But then we're lucky, because the gap is filled by straight teeth, links, and endostem. Let me go over this. So we are all familiar with the radiofrequency ablation of the gastroesophageal junction. We have the endoscopic fundoplication, which applies the fasteners and creates a partial fundoplication. I don't know what is your experience. I've taken down some of these, and sometimes it's a nightmare, because there has been a leak at the level of the fasteners, and it's very difficult to do the dissection. Well, in 2018, there was a consensus conference of the top esophagologists in the United States. You will recognize Carillas, Pandolfino, Castell, Vela, Speckler. They stated that before operating, you should have objective evidence of pathologic reflux. For objective means do a pH monitoring. Radiofrequency ablation should not be considered in any scenario, and similar for the endoscopic fundoplication. Now, I was following SAGES, and now what many people are doing, believe it or not, if they have a patient with an hiatal hernia, they ask a surgeon to do reduction by laparoscopy and close the hiatus, and then a gastroenterology will be TIF. That's why I was stressing that financial reasons, unfortunately, play a big role. But let's look at the other devices. Links, we're all familiar. It's a ring of titanium beads placed around the gastroesophageal junction, opens when you swallow and then closes again. There is no question that is effective, but it's still a laparoscopic operation, and especially if you take care of an hiatal hernia and close the crura, the control of reflux is due to links or is due to what you did. I think it's good for failure of other procedures, like if you have a major reflux after a sleeve gastrectomy and you don't want to convert to Roux-en-Y. But in the United States, it's $5,000. Rarely is reimbursed by the insurances. And then for some people like me that have been around for many years, there is the issue of a foreign body next to the esophagus. When we use the angel cheek prosthesis, seem to be very easy, and then we have to remove them. There was an honest study published by Luigi Bonavini in Milano. He found erosion with need for removal in almost 7% of patients. And then there is the endostim, the electric neuromodulation of the nerves in the area of the LES. So you apply the small electrodes at the level of the LES. These are connected to a subcutaneous reservoir battery. This toy cost $18,000 in addition to the cost of the operation. The company decided to have a prospective randomized trial, 2 great principal investigators, Nick Shaheen for gastroenterology and John Hunter for surgery. They thought to have an objective primary endpoint, which was control of reflux by pH. So again, there was a consensus conference. So need for objective evidence of pathologic reflux. In 2018, this gastroenterologist said LINX or endostim if no hiatal hernia is present. Actually, the endostim trial has been stopped because of complications, and the implanted devices have been removed at the expenses of the company, and the company will also pay major settlement for class action. The recommendation was to do a fundoplication if there was a hernia more than 3 centimeters, but nobody is following this. So there is no question in my mind that the financial aspect of these devices pushed by the industry plays a big role. So let me conclude by saying that PPIs, without any questions, are the mainstay of therapy for most patients with reflux. I think that laparoscopic anti-reflux surgery is the most effective treatment modality for reflux, but patient selection is important. You have to follow the proper indication, do a complete workup, and then proper execution of the technical steps. I want to remind you that the esophagus and the lungs are linked. You're going to help a lot of people that have aspiration. And finally, don't listen to the sirens. Again, my gratitude for this invitation and to be part of this panel. Thank you very much, and glad to answer any questions.
Thank you very much, Marco. That was fantastic, fantastic talk. Will, are there questions online there?
Yeah, I don't see any arriving into the portal, John, as yet. They may come in.
Marco, could I ask you, so in terms of managing the patients with obesity, who are obese with comorbidities and have significant reflux, I mean, how is that best done from a surgeon's perspective?
Well, recently I did somebody with a BMI of 45. So I did a Roux-en-Y gastric bypass. I will never do a sleeve because they reflux like crazy. But I did a Roux-en-Y, very, very small pouch, and then a 120 centimeter loop. So I think in a very small pouch, there are very few parietal cells, and 120 centimeter loop, they will not reflux bile. So they would be my operation of choice.
Yeah, Marco, I really enjoyed your talk and such practical kind of information for us to benefit from your experience. One personal question, and then I see one question coming in on our forum. In Europe, in some centers, patients with elevated BMIs, there is a vogue for performing a Nissen sleeve. Have you any personal experience of that, or how is that viewed in North America? And the second question, which has come in online, is from one of our trainees, Wakas Butt, who asks, I think during your video, and I noted that as well, I wondered whether you attacked your fundoplication to the esophagus. And Wakas asked the question that if it is not tacked to the esophagus, is there a risk or a chance of the stomach herniating through the fundoplication? So one question about Nissen sleeve, and then one question about the wrap and tacking it to the esophagus.
Those are two great questions. So I never done a Nissen sleeve, but I was in Argentina and somebody did it. And it's obscene because basically if you want to do the Nissen in addition to the sleeve, you have to leave the fundus. And remember, the fundus has receptive relaxation, so will tend to stretch. So your gastric reservoir is going to be pretty big. So I think in these cases, it's just simpler to do a Roux-en-Y. The second question is excellent. So in the 90s, my mentor, Larry Way and Carlos and I were putting apical stitches, getting esophagus pillar to avoid the proximal herniation. And we also put a lateral stitch similar to a heel procedure. To be honest with you, over time we realized that probably did not make any difference. And the mister has always been against it. So what I think makes a difference is if you do a good dissection, you have enough esophagus below the diaphragm without tension. So you remove all the instruments and the esophagus stays there, and then do a good approximation of the right and left pillar of the crus. Most of the time put in posterior stitches. Sometimes, especially for paraesophageal hernias, you have to put some anterior stitches.
Very good, thank you. John, I've one other question, if we have time.
We very briefly, Will, if that's okay.
I just briefly would ask you about, in Ireland, Professor Reynolds has very successfully centralised our cancer care, and we're a small population. I wondered about your views about centralising benign and anti-reflux surgery. Has that been done to any extent in North America, and do you think it's sensible?
I think it's the way to go. I think you guys are doing the right thing. So for benign disease, I can tell you that in North Carolina, there are studies now that have shown that people that do more do much better. So the volume issue. So I wish there was centralization, but even the insurance company have been against it for both benign or cancer of the esophagus. And the college is afraid to say anything because it's restriction of trade. So you guys are on the right path. I know that in Italy, they're moving towards centralization. I mean, if I had achalasia, I would go to Padua or Milano. There is no question about it. Yeah. Unfortunately, in the United States, it will never happen.
Thank you.
Thank you for the questions.
Fantastic. Thank you. Thank you again, Marco. So, Will, thank you.
Yeah, it's now my pleasure to introduce Professor George Hanna to the delegates. We're delighted, Professor Hanna, that you've been able to join us today, and thank you for being with us. Professor Hanna is well known in the United Kingdom and indeed Europe and worldwide. He trained under the tutelage, I believe, of Professor Sir Alfred Cushery in Dundee in Scotland, and in the first decade of this century, 2003, joined Imperial College, became the head of the Division of Surgery there in 2012, and then subsequently head of the Department of Surgery and Cancer in 2018. And I believe his clinical work is mainly based in the Hammersmith Hospital in London. Professor Hanna has many areas of research interests, including validation of non-invasive breath tests for the diagnosis of gastrointestinal cancers. He holds many positions of leadership, both within the United Kingdom and internationally. His further area of research interest focuses on the quality assurance and the measurement of quality and the performance of surgery in randomized controlled trials. And I believe it's with that in mind, really, Professor Hanna, that we're looking forward to your presentation today. It's entitled Measuring Quality in Cancer Surgery. You're very welcome.
Many thanks, Will, for your kind introduction. Thanks very much, John, as well for the invitation. Let me share the slides. You see the slides now, do you?
Yes, thank you.
Wonderful, okay. So, I'm going to talk about three main things. One, I just get some data from historic trials and clinical practice about quality of surgery. And then we're going to hope to answer two questions: is what to measure and how to measure it. The question really, do we need surgical quality in cancer? I would say surgery has direct influence in survival, and surgery is a curative treatment. Oncology modality are adjuvant treatment, especially for luminal cancer surgery. And actually, as a common sense, it's just unethical to do a suboptimal operation. For randomized trial, we realized that if you're going to have a surgical quality, this may slow the trial, and some center might not reach the quality assurance. So the question really is a balance. Do we have a bigger recruitment, or do we have a high quality recruitment? And there is always a question, really, does randomization equalize the quality in both arms? So really, so the quality will be the same in both arms. Will this really need it? And the other question really will be, let's just do real surgery, what happens in day-to-day practice, and it's a pragmatic trial. So these are the two opinions which people say about it. But if we look at some of the trial, this is the trial which led from my previous boss and or my current mentor, even Prof. Kosheri. D1 versus D2 trial, everybody knows that have problems because in lymphadenectomy was adequate in 75% of patients. But what's more important, that Prof. Kosheri written in Annals of Surgery that said that the results of this trial no longer a sustainable argument against D2 gastrectomy in modern surgery for invasive cancer. Like anything else in life, the trial has its own sell-by date. And actually, this is a PI of a trial, say the trial is really, shouldn't really stand anymore, right? Quite a good of courage to do it. Actually, Annals of Surgery took 2 years to publish this letter. The Dutch trial, again, we know, you look at the dissection was less than specified in D1 and more other way around, more in D1 and less in D2. And this led to partial humanization of both groups, and there is no difference in survival. So basically, you have two arms which really more or less the same. This is a MAGIC trial. If you look at the MAGIC trial, you look at the surgery is almost really coming to 40% of patients who has either palliative surgery or surgery not done or not specified. And if you look at the survival difference, actually, so 11% more patient in the surgical arm has palliative, and the survival is 13%. And so there'll be always an equality issue if you have 40% of your patients is not according to a specified operation. Then we did a meta-analysis on the transhiatal oesophageectomy operation. I don't do often. I don't do at all. What we found that no study has met the minimum quality criteria, and lymphadenectomy and reported quality was suboptimum in both groups. So really, if you have trials between transhiatal and transthoracic, and none of the trials reach minimum quality criteria, you always question the expected outcome. Then what we've done is we looked at the data between the Western countries and the Eastern countries. And what we found in the East, there's an association between gastrectomy and survival and reduced recurrence after adjusting for the age, the gender, the chemotherapy, tumor stage, and nodal status. So whether it's an early or advanced cancer. So there is an association between if you operation done in the East and survival. But it's like the people who went into Japan and Korea, and you see that they do it like was a samurai attitude, and there is a limited number of high volume center contributing to the trial, and this has a proven track record. And there's always emphasis on the quality of surgery. This is not an optional point. Then we did a we looked at the landmark trial in esophageal and gastric cancer, and with the trial which included quality control and the trial which did not include quality control measures. And there was surgical quality in a randomized trial improved in hospital mortality. There's an increase in lymph node harvest and decreased local recurrence. So really there is an association between quality assurance and outcome in trials. And if there's no quality assurance, it will be very difficult really to have a proper interpretation of the trial. The question really is what to measure. Anything else in life has a unit of measurement. So the question really, in surgery, what is our unit of measurement? There is a weight, there is a height, but in surgery, the main unit for measurement and really is the mortality and sometimes complications. And this is, I think it's almost historical and still carrying out it now. Show you something. This is the picture after the Battle of Waterloo. What is happening? The battle finished and now they are counting the bodies. So, and actually, if we think about it, that's what we do in surgery. The operation finished, actually big number of operation finished, or a trial finished, maybe middle of the trial or the end of the trial. And then we count what are the incidence and what is the complication rate and mainly the mortality rate. So effectively really is the damage has already done. So do we really in our audits almost doing exactly the same? This is after the battle of finished, we counting the bodies. Now, audit data allows adverse events to accumulate while the audit is in the process. We have to get a reasonable sample size because a small number wouldn't really make sense to do it. And there is no relation between the oncological quality and the early mortality. It's completely different. One is a long-term, one is a short-term, unless the audit is done about long-term survival, but this is hardly done. And we can't correlate complication to a specific errors. Like you have seen the previous dissection, you can do a perfect dissection, or you can overshoot with the hook, which doesn't hit anything, doesn't cause any problem. Or you can overshoot with the hook, come to a vessel, cause bleeding. Or can you overshoot with a hook, and come to the abdominal wall, which do a burn, but doesn't cause any problem. So a complication, one movement can have different consequences. The other thing, leak from a joint, could be because of the tension, could be because alignment of the suture were not good. It could be the blood supply and selection. So a complication can be caused by different factors, and one movement, one error can cause different complications. So we can't correlate complication and errors. The other thing is the error can't contribute to the outcome. You don't know really whether the operation, because of the trainer or a trainee, is very difficult to dissect them because it's almost a joint decision-making intraoperatively. So you can't really look at the training curve very well from the audit data. And we can't discriminate between component of competence. So the outcome actually of surgery, not just technical decision-making, and there are other factors which influence the outcome of a cancer unit. And then most importantly, really, audit can't really tell how to improve technical performance. So audit as a blunt instrument alone may not provide the way how to improve. However, the audit, it can show general trends in national levels. It can comparative performance. You get a very, very, very big data science, you can tell whether the leaks is lower or higher with laparoscopic or open gastrectomy or oesophageectomy. And it can show us at a national level, show progression of time. Look at the data in the UK, you can see improvement in the mortality over time. It's almost a reassurance policy rather than a mechanism to improve performance. So just give you a couple of examples. So here, this is did a review at the learning curve of esophageal cancers laparoscopically when introduced in the UK. And you find here is there is a inflection here point in the Cushing curve between 10 and 15 cases. There are 30 days, 9 days mortality is around 15 to 20, again, reintervention and conversion, which means that people die while introducing technical aspects of an operation. There'll be always a learning curve, but you can accept the learning curve on a time or other factors, but to accept the learning curve on a mortality basis, this is really will be no longer accepted. The colorectal training program, the LabCo program, they have a competency assessment tools into it, and the outcome of the program that people after they leave the program, they have increased the laparoscopic rate, improved morbidity and mortality in England, and in training competency assessment predicted performance after training. So the idea of having a system which measures the competency will improve morbidity and mortality and will predict the performance when people go for independent practice. And for this program, this for consultant surgeon, I was involved because of I'm independent and my interest in the methodology. But the LabCo program showed that consultant can accept competent assessment, and it improved morbidity and mortality at a national level. The question really is, can we have the errors as a measurement unit? So driving test, if you go through a red light, people fail their test. They don't wish to crash their cars. Aviation and nuclear industry don't depend on how many disasters happen. They look at errors. And again, in the LabCo program, they use error analysis. And you should see here, experts from people who passed and people failed, there is a different number of errors. So you don't really need to wait for the complication to happen to know what the performance looks like. So to measure the performance, if we are not going to take the concept of complications and mortality alone, we can look at two things. One, the errors. There are errors with no consequence, and errors requires corrective action, and the error result in complications. So there are different grades of errors. The second one is the context. An error which happens, so actually operation really should be divided into a tolerance zone. There are some areas which is a high risk. Maybe if you're doing the lymphadenectomy along the portal vein is different from open abdomen, or doing around the common hepatic, or if you're going to do a division of the short gastric is different from doing the splenic hilum lymph node dissection. So the operation will be a low or high risk zone. So measuring performance technically using the errors rather than a complication mortality may provide a mean more sensitive and doesn't allow complication to happen. The same as the driving test and the same that any other industry. There's not many professions using mortality as a measures except in wars really. So so first thing is the errors. Lymph nodes, the problem with lymph nodes is we don't know what is the quality of the pathology. A surgeon will say, I've done a proper lymphadenectomy, and pathologist said, well, it's not me, I count what I get. The reason for this is because we don't have a standard for lymph node retriever by pathologists. We have a standard for reporting, but we don't have a standard for retrieval. It said 15 lymph nodes, which a concept which I can't understand. But we did a study and few thousand lymph nodes at Imperial, and about 40% of lymph nodes is less than 40% of positive lymph nodes less than 5 millimeter. So half a centimeter lymph nodes is an important lymph node. So we can't use the size alone as a measure, and we don't have a standard of retrieval. It's purely depending on the pathologist. And we have to remember that the lymph node is a surrogate marker. It is not the actual marker, because what matters is what we leave behind, is what just takes. The lymph node is a surrogate marker for the clearance of the lymph nodes. And it is a pathology dependent. There are different studies show that, and it's common sense actually, depending who look at the lymph nodes. And all the guidelines we have, it is about reporting, not about retrieval, and not about how many blocks of lymph nodes you take. If you take one block, different from more than one block. If you take the whole, every lymph nodes in the specimen is different if you're going to sample 15. So lymph node really, although we can't ignore it, but so variable and so pathology dependent and so uncontrolled, is very difficult to take as the only marker of surgical quality. The third thing is the quality of the end product, the dissection field. I think this is what really, really matters. Because at the end of the day, the lymph nodes, which you would count in pathology, it's what we removed. It'll give us an idea. But what will make the difference to the patient is what we leave behind. Do we leave something behind or not? Because if we don't, definitely better than if we do leave cancer behind. Pathology can give us an idea, but the ultimate judge is what we leave behind. Because cancer surgery is not operating on the organ which you are going to remove. Cancer surgery is we are operating on surrounding structures. So if you're going to do a gastrectomy, you're operating on the pancreas, the celiac axis, the splenic hilum, and the posterior abdominal wall. Maybe going out to the oesophageectomy, go to pre-aortic fascia and precardial adventitia, and taking right and left pleura, and then you go to the carina. So effectively, cancer surgery is an operation on surrounding structure. So the best way to know its quality is to look to the surrounding structure to see whether they are cleared or not. Because the most critical for long-term survival is what we need behind. The pathology will tell us what we left, but a photograph, what we removed, but a photograph will tell us what we left behind. The question really is how to measure this. So video photograph-based assessment, actually, it is pretty good way to do it. It is easy, of course, in laparoscopic surgery to do, and even it is open. Getting a photograph or a short video of the operative field, that's not difficult. Actually, just do it even with a mobile phone. A key point is use objective predefined methods and criteria for assessment. Of course, surgeons who are have a lot of experience, they can look at the field and they will know. But if you're going to make it a standard, if you make it common, if you make it in a practice, then we need to have an objective criteria. And initially, when I did my research, doing my PhD and other things, we were reviewing the whole operation. But actually, we can also review key component of the operations. If you're going to look at the process of operation. Look at the process, how people do the dissections, whether error happens or not. You can just see a sections. But I think one of the key things actually should be happening, because now we'll have video a few minutes after the end of the operation, and with automated image analysis, machine learning based system, that could be reduce the time and increase objectively immensely. So really here is how to measure at the end is take a short photograph, get the quality of the end product at the end of the operative field. If you'd like to know the process, whether make errors or not, you can take short component of the operation. And there are techniques like ergonomics technique, human reliability analysis technique. It takes time, but automated systems are more easy to do now. And actually, this is happening. So there is a competency assessment tool for oesophageectomy, for color-3 trial, which is actually implemented in every case very nicely, and for endometrial cancer surgery. So in trials, there are more and more using it. It needs to be set up before, at the start of the trial, not as an afterthoughts after doing the trial to take a box. Now, training actually, that will be more and more happening. So the American Board of Surgery exploring a video-based assessment as a pilot program. And this is happening as a pilot program, and the question really whether they will go ahead and will be part of the certification. I know that the European Association of Endoscopic Surgeons are looking at the program, and hopefully next year will be a video-based program to assess competency. So the home take message is audit alone is not a good indicator of surgical quality. As we said, it's just the damage is already done. It is after the Battle of Waterloo, just the damage happened. What we measure, we can measure the process. We look at the error with the context of tolerance or high risk zone. We look at the quality of the operative field. A photograph or a video at the end of the operation will tell us the quality of the end product. Lymph node count is still important, but it needs to have a lot of standardization if it has to be, if it is used as a marker of surgical quality. How to measure this? Image-based assessment using pre-existing, predefined criteria. I think this is a simple way to use it, and automated system. There's a lot of work happening actually, and so it will not be done really quickly and at a low cost. Thank you.
Professor Hanna, thank you very much. That was a fascinating talk. We're running a little bit short of time, but John, do you have any questions for Professor Hanna? I don't see anything just in on the forum at present.
Not really, no. I don't think we have time, George, but I mean, I think you've struck a chord with everybody who's involved in surgical oncology, whether it's pancreas, esophagus, stomach, anything. This is a huge area, and one you're leading, and we all buy into it very much, I would think, in terms of what you're espousing. I don't have a particular question. We could talk all day about it. I don't know if anybody else has. If not, George, thank you so very much. Brilliant talk. Thank you.
Thank you.
Will.
Professor Hanna, thank you very much. It's my pleasure now to present Professor Helen Heneghan. Professor Heneghan needs little introduction to her Irish colleagues, but she graduated from NUI Galway, completed a PhD in 2012, and completed her surgical training in Ireland in 2016. During her training, Helen spent, I think, 2 years in the Bariatric and Metabolic Institute in the Cleveland Clinic in Ohio, and subsequently did a fellowship in bariatric and metabolic surgery in Chester and Liverpool. Professor Heneghan is, of course, the Professor of Surgery in St. Vincent's University Hospital here in Dublin, and is our national lead for metabolic and bariatric surgery. So Helen, it's a real pleasure to introduce you today, and I'm really looking forward to your talk entitled Metabolic Bariatric Surgery prevention and management of operative complications. Over to you, Helen.
Thanks very much, Will, and thanks to both you and John for the invitation to speak on a topic that sadly have a lot of, by virtue of years of experience, not that much, but in recent months and the last couple of years, a lot of experience in managing bariatric surgery complications, predominantly as a result of medical tourism, as I'm sure any of the all the upper GI surgeons in the audience will have experienced the same trend. Well, just for any non-bariatric surgeons, refresh your memory of what the commonest bariatric surgery procedures are. I've included the gastric band here because there's a legacy of thousands of patients, certainly in Ireland, who have gastric bands in place. I haven't placed a gastric band in the 5 years I've had a consultant post. I'm not sure again if you place them but I certainly see very little role for them when the safety profile and efficacy of the other procedures is preferable. But I include them here because of the complications that we see on a week-to-week basis with gastric banding. The most common operations performed now for primary bariatric surgery is sleeve gastrectomy and gastric bypass, of which there are two surgical techniques. The room-wide gastric bypass obviously remains the gold standard, but there is a role for, I certainly see a role for the one anastomosis gastric bypass for people who ultimately would benefit from all the metabolic benefits of a gastric bypass, but whose BMI may be too high or who may have abdominal obesity to a level that precludes performing a safe room-wide gastric bypass. And again, one anastomosis gastric bypass is very commonly performed in Eastern Europe. It's a less costly operation often than a room-wide, so we see complications related to that quite a bit. I've included a couple of other less commonly performed bariatric operations, again, because we see the sequelae of these back through the emergency department. The gastric balloon. Again, even just this morning, we've had to remove a gastric balloon placed in a clinic abroad a few weeks ago, and a patient who developed intolerance or from the outset has been intolerant of it. So I've included a couple of points on balloon removals later on. Gastric plication comes in and out of favor over the years as an alternative to a sleeve gastrectomy, but to eliminate the risk of staple line bleed and perforate and leak. It's never really taken off any time it's been in vogue because it doesn't really eliminate the complications of certainly of leak, and it's not as effective and fraught with complications such as prolonged nausea, vomiting and obstructive type symptoms, and we've had to undo a few of those over the last few months and years. So again, bariatric surgery, I suppose from the outset, although this is a talk about complications, I think it's really important to say it's a safe and effective procedure for severe obesity. Its safety profile has, I suppose, was transformed by the adoption of enhanced recovery after surgery programs, and underlying all of that was the transition from open to laparoscopic surgery in the early 90s. But ultimately what ARAS protocols for bariatric surgery have achieved is a really low mortality rate, so less than 0.1%, which would be equivalent to cholecystectomy mortality, and major complication rate in the order of about 1%, and minor complications, so cavity dido 1 or most grade 2 would be in the order of 5 to 10%. So I'll move on swiftly then to the complications of bariatric surgery. There's some general complications, obviously, that apply to any of these procedures. In the early period, the commonest complication would be nausea and vomiting leading to dehydration. This is the commonest reason for delayed discharge and for readmission, but it's infrequent and occurs in less than 5% of patients, and is best treated with dietary advice and slow dietary progression. It's very rare we would have to discharge someone on antiemetics. Often this settles early after surgery, and if it recurs when patients are home, it's often because they advance their diet to more solid texture too quickly. The dreaded complication in the early, say in the 30 days after bariatric surgery, is a PE. That's the commonest cause of mortality where mortality does occur. So we go to great lengths to prevent it through early mobilization, sequential compression devices, and extended chemical prophylaxis. So I would discharge almost all patients on low dose, low molecular weight heparin for 3 weeks after surgery if they've had a sleeve or a bypass. Then later complications relevant to all procedures would be nutritional deficiencies. And at some point over long-term follow-up, 50% of patients will have a nutritional deficiency identified. It's important to prevent them through ensuring compliance with supplements. The commonest deficiencies we would see, despite Supplements would be iron and vitamin D deficiencies. And again, they're common in the population in general, so it's not too surprising. Thiamine deficiency is uncommon, but because it's so serious and can be difficult to diagnose, it's always important to consider it, particularly in patients who come with complications leading to nausea and vomiting. And then gallstone are quite frequent after bariatric surgery from rapid weight loss. And again, I've mentioned later on as to how we prevent them. So I'll move on to the procedure-specific complications. And again, I'll summarize them here, but go through each of the procedures, one or two of these complications in a little more detail. The specific complications for gastric banding would be gastric band slip and erosion, or functional complications like esophagitis and dysmotility. For sleeve gastrectomy operations, the dreaded ones would be gastric staphyline bleed, apologies for the typo, a leak, and then a narrowing of the sleeve either due to a stricture that has evolved over time or due to the sleeve being made too narrow in the first instance, and can also occur because of a kink or spiral, which usually occurs at the level of the incisura. And I'll go through ways of ensuring we can prevent that from happening. Room-wide gastric bypass complications would include, again, leak and bleeding, but also less serious but more common would be stomal ulcers and strictures. And again, less common but serious internal herniation of small bowel or bowel obstruction. And the gastric balloon, as I mentioned, intolerance is a common complication from that. So moving on to, I'll talk through the two commonest, I suppose, technical complications of gastric bands being slip and erosion. Preventing these, again, I've very little experience with band placement, I'll be completely honest, to perform some on fellowship, but none as a consultant, again, because I don't see much role for it. But if anyone is placing bands, I suppose correct band placement involves using the pars flaccida technique that changed in the early 2000s from, it was inserted by a perigastric technique, which left too much stomach pouch, particularly too much of the posterior wall above the band, and led to frequent band slips and herniation of the posterior wall of the stomach above the band. So the pars flaccida technique just involves making a really narrow tunnel in the posterior gastric fatty tissue at the level of the OG junction and just inferior to the crural confluence. And then it's important to, if placing bands, assess the crura and see if a hiatal repair is necessary to prevent gastroesophageal reflux, which can be troublesome with gastric band, even if there isn't a hiatal hernia, but certainly it's aggravated if there is presence of a hernia. It's important if placing these to place 3 lateral plication sutures to prevent movement of the band, and again try and minimize the potential for a band to slip. And importantly, in terms of gastric band management, to place the port at a site that's accessible and that it's flat, so that whoever is doing gastric band adjustments can access the port easily. Then I suppose more relevant to preventing gastric band complications through band management, cautious band inflation if people are presenting for gastric band fills is important. And again, as you know, I've learned the lesson of being too generous with the gastric band fills as recently as last week, when I often find patients can pressurize you into trying to fill a band or not disclose they've had previous band fills. So I would always check band volume at any band fill and be more cautious in terms of adding volume to the band, going slower, because it only leads to obstructive symptoms, and patients often downplay those when they really want band fills, assuming that the tighter band is more effective for them, which isn't the case. So going really slow with band fills, 3 mils the first inflation, then 2, then 1, and then being really cautious with half or even quarter mils to get to this sweet spot where patients have ideal satiety. Any faster than that and obstructive symptoms and a slip are more likely. So I'm going to talk to 2 cases that I've managed over the last few years. This is one from 3 years ago, a 52-year-old male who presented to the ED with a history of having had a gastric band placed in 2013. Which hadn't worked well for him. I think he'd lost about 15, 16 kilos initially, but had regained all that weight and probably some more. And he only presented to his GP when he'd seen he didn't know what this was, but he saw the gastric band, he saw this, as he called it, the white thing on his abdominal wall. It's clearly the gastric band port, and lateral to that, some of the tubing. But in addition to that, he had a 1-week history of pain in his left upper quadrant and 24-hour history of nausea and fever. Examination-wise, his abdomen was soft, it wasn't tender. It can be difficult to examine patients with that severity of obesity, and abdominal examination isn't often that reliable, but certainly he didn't seem to have any concerning abdominal signs. He had a fever, but otherwise normal vital signs. And just anytime you see this, you see evidence of a port protrusion or tubing protrusion on the abdominal wall, it's almost always pathognomonic of gastric band erosion. Not all band erosions will present like this, but when you see the port on the abdominal wall or any irritation at the port site, have to be suspicious of a gastric band erosion. So management of this, it's actually not, quite often it's not an urgent scenario. Patients has been eroding for some time. So they're typically, they don't present with severe abdominal sepsis. He had some evidence of it, but is still placed him on IV antibiotics and fluids. Imaging isn't really essential for suspicion of gastric band erosion. We find imaging is a limited role in patients with severe obesity because often you're limited in your access to it. But for this, it wasn't essential. He had a CT abdomen that was obtained in the ED department. It doesn't always show you the extent of the erosion. In him, it was obvious that most of the band was in his stomach, but the key investigation for this is endoscopy. And this is what I saw when we did the endoscopy for him. This is the gastric band. This is a retroflexed view of the OG junction. And this is most of the gastric band having eroded into the stomach. This is the first of such I'd seen, and hadn't really any experience with removing eroded gastric bands. I was aware that there was a technique to remove them endoscopically, and that removing them by laparoscopy or laparotomy was quite difficult. Again, because you have to do a gastrostomy, obviously, and the morbidity of that was higher. So for this, I sought to perform the first endoscopic gastric band removal, which meant trying to get hold of this gastric band cutting device that's specific for this procedure, which took a couple of days to get in, which thankfully his clinical condition allowed for. But nonetheless, it made removal of this band far less morbid for him to be able to do it endoscopically. Just in terms of nuances of this, I've since learned that to be able to do gastric band and to remove an eroded band endoscopically, it's important that most of the band is in the stomach. If only a small amount of the band is visible, then it's best still remove laparoscopically or by laparotomy, because you need to be able to get enough, you need to have enough laxity in the band to be able to get a wire around it and be able to remove it to do this. So you can wait for more of it to erode, but on several occasions since, when I've tried to remove eroded bands endoscopically, on 2 of 5 occasions I've failed because I've gone in either too early or it hadn't eroded enough, and I've still had to resort to laparoscopy or laparotomy to remove them. But nonetheless, the technique here is to pass a long metal wire through underneath the band. It's best done again in the retroflexed position. Pull that out with the forceps and then use this metallic sheath. It's inserted through it to this hand grip device, and there's a tourniquet mechanism where it's twisted down and cuts the band. It's a bit like a cheese wire, cut a piece of cheese. So it breaks the circular system and allows you to get a polypectomy snare then around one of the ends of the band and remove it through the mouth. Before doing that, you have to disconnect the tubing. So he required an incision. The port was visible and the tubing was visible anyway, but I cut that to be able to remove it out through the mouth. And there I was really happy with having removed the first one, but the next 2 failed again because I didn't appreciate that enough of the band had to be in the stomach before it's possible to remove it endoscopically. So a far more common complication is a gastric band slip. And this is a really typical scenario that we see here almost once a week at this stage. 49-year-old female, remote history of gastric banding. For this particular lady, it had worked well, had maintained a weight loss. And when that is the case, patients are loath to remove them. So they really wait until they're desperate before they come in, and they're really reluctant for you to remove them. Well, this lady had a 1-month history of severe reflux, did nothing about it. She was vomiting solids for a month, resorted to liquids, but then couldn't keep them down for 3 days. She became dehydrated, mildly tachycardic, and a slightly low blood pressure, but mildly tender in the epigastrium, but denied pain, which is important. Gastric band slips, there's 2 particular types, posterior, anterior, and that refers to the amount of stomach or where the stomach herniates through the band. So posterior slips are less common. That's where most of the posterior wall comes up behind the band and causes obstruction. And then the more common scenario is the anterior wall or body of the stomach protrudes through the band, again causing obstructive symptoms. In terms of assessing for gastric band slip, the symptoms can be quite suggestive, but a plain film X-ray can be quite helpful in determining the position of the band. The phi angle is the appropriate angle a band should be at. So it's the angle between the vertebral column and the lie of the band, and it should be approximately 45 degrees. And if it's more acute than that or more obtuse, a greater angle, then you're concerned about a band slip. In the lady I was discussing, this is what I saw. This is evidence of a significant anterior band slip, and this is often in bariatric surgery called the O or Polomon sign, where you can see the whole rim of the band, just like an O. So again, that's quite consistent with a gastric band slip. Management of this is deflate the band as soon as possible. That's the most important thing to do. Often that will resolve symptoms and a band slip in up to 50% of cases and spare a patient having to have the band removed. You can start to refill it if an imaging demonstrated that the band had gone back into a good position after it was deflated, which, as I said, it can do in up to 50% of cases. But if it doesn't settle after band deflation, then it requires removal. I don't offer band repositioning, again, because they slip in 50% of people after that. I don't think it's it gives a good enough result. But sometimes patients will ask you to just unbuckle it and leave it for whoever placed it to reposition it. So I'm loath to offer that, because often you can damage the band in trying to unbuckle it. So my preference is for band removal if there's persistent evidence of a slip after deflation. And just by means of anyone who does get gastric bands or slip gastric bands presenting, deflating it isn't as easy as it might seem. Can be hard to feel the ports, because people often still have severe obesity despite the gastric band being placed for weight loss. The patient will usually be able to guide you as to where their port is, but it can be difficult to feel. And it's important to have the appropriate needle, a long Hooper needle if possible. The ones in radiology or oncology I find are too short for the depth of most patients' abdominal wall, and any alternative like a spinal needle is too flimsy. It often won't penetrate through the silicone of the band port. So having a stash of these is actually quite important to have if you're an upper GI centre and see this problem frequently. And as I said, if symptoms don't settle when the band is deflated, I personally would recommend removing it as opposed to repositioning it. If the patient has epigastric pain and symptoms of a band slip and imaging consistent, that's ominous, and I would have a really low threshold to remove that band even after deflation. So epigastric pain is usually a sign of there's a concern about ischemia or compromise of blood supply to the stomach, and this is what you typically would see: really congested stomach with imminent the threat to the proximal stomach, which would be a real worry. So even deflating doesn't often resolve that enough to get away with keeping the band. So I'll move on to sleeve gastrectomy complications. Briefly, the staple line leak and bleed are uncommon, but they're probably our most dreaded complications from sleeve gastrectomy. In terms of prevention of leaks and bleed, stapling technique is really important. So choosing the correct staple height, whether one's preference is to use the endo-GIA or echelon. I use both, and I would use purple staples or blue for the first couple of fires lower down in the stomach. If it's the going through the antrum or body of the stomach for a sleeve, I would use purples. I don't use blacks. You need a 15mm port to do that, and I've rarely found it necessary. And then switch to tan staplers or white ones if we use an echelon as I go proximally. And using the stapler correctly, having it flat, taking time to let the tissue compress, and not firing it too fast is really important. Staple line reinforcement is controversial. I suppose I don't reinforce staple lines routinely. I will selectively oversew if there's evidence of bleeding, despite using the stapler correctly. And recently, one of my fellows, Paul Cromwell, has looked at all of the evidence for staple line reinforcement, from oversewing to using buttress or commercial staple line reinforcement, and looked at the cost effectiveness of doing that in all cases to prevent. It's clear that those techniques do reduce the risk of bleeding by about 50%, so can reduce it from 2% to 1%, but there's a cost involved. Oversewing is probably the cheaper option of that, although it takes operative time, and buttressing with seam guard or any of the other commercially available buttresses is expensive. Each one costs about 120 euros per staple firing. So if you use 6 or 7 staple firings for a sleeve, that cost racks up pretty quickly. So I would do it, you oversew selectively to minimize bleeding. And then some units use tranexamic acid routinely. We did in Chester, give tranexamic acid pre-operatively and 3 doses post-operatively, and did produce pretty weak evidence, to be honest, that made a difference to decreasing transfusions, although they were so infrequent. I'm not sure the numbers in our study at that time were enough to justify its use routinely, but it's not known to increase thromboembolic events if it is used, so it's an option. Management of staple line bleeds, if they do occur, have a really low threshold to intervene early, wash out the hematoma or clot, and oversew the staple line. As opposed to conservative management, if a patient is stable, it still decreases the length of stay, the risk of a hematoma becoming infected, and the risk of blood transfusion if you intervene early. And then thirdly, with the sleeve, I know I'm running short on time, to prevent a sleeve narrowing or kink, always use a bougie or gastric tube. I use 34 French, it's the only one I have available here, or occasionally an endoscope. But units, the size of the tube doesn't matter so much as to definitely use one to prevent making your sleeve too narrow. Don't go too narrow to an incisura. Don't go too close to the OG junction more proximally. Keep the staple line straight to avoid a spiral staple line. And I don't do one-stage revisional operations. If patients have had a gastric band before, I would remove that, wait at least 3 months before committing somebody to a revisional operation. There's very little evidence for an omentopexy to the staple line as a means of preventing a sleeve from narrowing at the incisura or spiraling at that point. And then if it does occur, the treatment options vary from endoscopic treatments with balloon dilatations and stents. I find they rarely work, and your best option is to convert to room-wide gastric bypass and to divide the sleeve above the point at which it's spiraling or narrowed. And then again, I'll move through this really quickly. A gastric management of a leak is similar to that with any upper GI surgery, but we see this frequently. Again, patients coming back having been 7-10 days post-op of usually a sleeve from having been performed abroad, and they're discharged home, often unwell, and turn up here 5-7 days later quite unwell. Typical scenario here would be a person who has a fever, tachycardia, and abdominal exam, as I said, isn't often helpful in these patients, but the clinical history and vital signs would suggest or make you worried for a staple line leak. Management of these, again, similar to any upper GI leak, is MPO, fluids, antibiotics, PPI, and for anyone who's vomiting for a few days or has limited oral intake, I always give thiamine. Imaging for these has a limited role, often again because the weight limit of many CT scanners is 200 kilos, and our patients would often surpass that, and its main use is to see is there a drainable intra-abdominal collection, but to diagnose a leak, fluoroscopy is most useful. So typically use a gastrograph and swallow study. And then again, early intervention for bariatric patients, regardless of the complication, is important. It's diagnostic and therapeutic. So have a low threshold to do an early laparoscopy, and for leaks, an early endoscopy, because I do find in about 50 to, even higher than that, many of the times you'll achieve closure of a gastric sleeve leak with endoscopic means, either using Ovesco clips, covered stents, and recently we've tried to use an endovac approach to close a staple line leak. If that doesn't work, you're committed to a total gastrectomy or subtotal gastrectomy for chronic leaks that won't heal otherwise. And look, I know I'm out of time, so gastric bypass complications, I'll just briefly mention, I think internal herniation is one of the commonest ones that does occur. I mentioned ulcers and strictures, which are more common but less serious, but internal hernia, again, it's one of those complications that has to be considered in any patient who's had a room-wide gastric bypass and presents with abdominal pain. It's often out of proportion to what you see or find in an abdominal exam, but we have a really low threshold to do a laparoscopy for patients with abdominal pain after room-wide. It's routine now in terms of preventing these. You have to close the internal hernia defects at the time of surgery. You can do that with a non-absorbable suture, or I use the endohernia closure clips, which I find they're faster, and they do they achieve the same closure rates. And in the literature, the evidence suggests they're as effective as sutures. But if I have a patient back with an internal hernia, I will always use a non-absorbable suture to close the hernia defect definitively. Beware with internal hernia patients, patients, imaging can be normal. So I don't get reassured by normal imaging in a patient with pain after Roux-en-Y gastric bypass. So really low threshold for laparoscopy, and in general start at the terminal ileum and work proximally to clarify your anatomy and reduce one of these. And lastly, I'll just mention the prevention of gallstones. We always prescribe ursodeoxycholic acid if patients have a gallbladder, and I've recently done a systematic review to clarify that the correct dose is 500 milligrams daily for 6 months after a sleeve or a bypass to minimize the risk of gallstones and the need for cholecystectomy post-op. Lastly, with the balloon, just if anyone's removing these, it's important to use a balloon removal kit. It's far quicker to do it. They do cost 460 euros, but the needle to deflate the balloon ideally should be this. Using a needle for injection, a normal endoscopic needle won't penetrate through the balloon and deflate it appropriately. And the specific pincer grasper that comes with this kit is important for retrieving the balloon and pulling it out easily. So I'll finish there. I'm sorry I've taken too much time and probably haven't time for questions, but I'd be happy to take any.
Helen, thank you very much. That's a really comprehensive and fantastic run through there. There are a multitude of questions I'd love to have time to ask you about, but I think actually a really good overview for everybody nationally who run into these complications or see them presenting through their emergency departments. So I think probably extremely helpful for a lot of the delegates tuned into us. Professor Reynolds, do you have any questions, or could we?
I agree. We could spend the whole session on all the talks so far this morning, and particularly and that Helen, and maybe next time we will. But that's huge information, and for everybody tuned in, beautiful presentation. Thank you very much. I'll just go ahead now, and I'm going to be brief, and I'm really going to try and trim this down into 10 minutes. Oh God. Yeah. Is my talk there at all?
It's not coming up. I don't know if Helen is there. Who could?
Oh, here it is. Yeah, here it is. Okay, so literally, I was just going to talk about an update on clinical trials with respect to esophageal and gastric cancer, and with a particular focus on adenocarcinoma, and particular focus on locally advanced diseases treated with curative intent. And the big issues here really are how similar from genomic studies and biological studies esophageal and gastric adenocarcinoma are. We know this, and therefore the trials really should reflect that, and we should perhaps begin to view most esophageal and adenocarcinoma, gastric adenocarcinoma as the one disease in terms of designs of clinical trials. The big question, number one, is whether nowadays whether preoperative radiation has a role, particularly in view of the fact, and this is, straight up George Hanna's theme, if you like, the quality of surgery, we hope anyway, and on-block resections and extensive lymphadenectomies are becoming more standard. So whether radiation is giving you anything extra in that context is one key question. And the other is the explosion of new trials across oncology with immune checkpoint inhibitors, and it's really finding a role, whether it's in the adjuvant or the neoadjuvant setting. So I think these are the two big themes. Cross has been the standard bearer for chemoradiation therapy for a long time, and for perioperative chemotherapy, which is the alternative, and most commonly used in the UK and France and many other countries. The MAGIC regimen was up to relatively recently the standard bearer, and then since the publication, certainly in 2019, the FLOT regimen. So I'm just really in the interest of time, I'm just going to talk really about two trials. And one is the NeoAGES trial, because it was administered by Cancer Trials Ireland, and many of us have participated in that. And this is the initial design of the trial was really to ask the question whether, well, exactly the question was, is radiation really a benefit in the modern approach to curative approach to esophageal adenocarcinoma, esophageal and junctional adenocarcinoma? And it was initially powered on the radiation arm, the cross arm being better, 10% superior to the MAGIC arm, which was the standard, and the primary endpoint was overall survival and a load of secondary endpoints, the usual types of secondary endpoints, which are oncology metrics. The trial was unique in several ways compared to what went before. All patients had CT PET, most patients had EUS, so there was good staging ab initio, which was great. Again, unique in having radiation therapy quality assurance. And again, thanks to Brian O'Neill from the RCSI and Tom Crosby in the UK for overseeing this. So all centres had to submit RT process documents and have pre-accrual outlines of benchmark cases, planning exercise reviewed and so on, and errors in planning treatment volumes and doses to organ at risk. They were all addressed, and centres were audited then through the time of the trial then in a random way with 10% of cases. So that was great. And also the other thing we were able to use is the standard international consensus definitions of complications after esophagectomy, because again, this has been a weakness of previous trials, not given sufficient attention, and particularly in the context of radiation therapy, possibly increasing post-operative mortality and major morbidity, in particular respiratory, ARDS and respiratory failure, pneumonia, but also an anastomotic as well. So very important secondary endpoint in that context. So agreed, defined consensus definition. So the trial went from 2013 to 2018 with cross versus MAGIC. And then with the publication of the FLOT4 trial, which showed superiority for gastric and gastroesophageal cancers with FLOT compared with MAGIC, then the FLOT was permitted to be used from then. And instead of having a superior power calculation, it was a non-inferiority power calculation from that. And that was based on the FLOT regimen coming in and being approved, and also the first futility analysis of the trial at 71 deaths, which showed things were pretty equal in both arms up to that point. So the trial in part was presented at ASCO last year, and really that's what I'm going to show you. This is the recruitment, 377 patients across 25 sites and 5 countries. It didn't really get going until the mid part of 2015, when the UK got its regulatory approval to start, and a number of sites joined. And over the experience, 134 Irish patients from Irish centres participated. So the main data, everything was pretty similar. Only 15% of the patients, because of the timeline of the trial, had the FLOT regimen. The vast majority had the MAGIC regimen in RMA. Most patients had clinically predicted node-positive disease. The vast majority of patients had transthoracic en-bloc esophagectomy, and relatively few had minimally invasive esophagectomy, about 18%. This is the main result. The main result was that there's no differences between the two at the second interim analysis and for the ASCO presentation. What we observed was a 3-year survival with perioperative chemotherapy of 57%, which is pretty good, and for the cross arm of 56%. And that works out as a hazard ratio of almost 1 and a confidence interval of 0.74 to 1.42. So at that point, we could say they were oncologically pretty equivalent. What about the secondary endpoints? Well, in terms of post-operative mortality, 3% for the radiation arm versus 2%, no great difference, no differences in leaks, no differences in pneumonia, a slight increase in ARDS, as you might expect, but not statistically so, and no differences in respiratory failure, notwithstanding. Similarly, anastomotic problems and atrial fibrillation, exactly the same. And overall, the severity of complications, so clavien-dindo 3B and 4A, 4B, exactly the same, about 11% in both arms. So how about toxicities and stuff like that? Well, not surprisingly, neutropenia was more common in the chemotherapy arms, diarrhea and other chemotherapy-related side effects. And in terms of the chemotherapy use, and this is a big thing, and 92% of patients were able to get all their chemotherapy before surgery, but only 42% were able to get all their cycles of chemotherapy. How about the metrics or the proxy markers of oncological impact, where you might expect chemoradiation to have much greater impact at the local regional site? Well, that's reflected really in the YPNO, so the post-treatment node negative arms, despite being the same preoperatively in terms of node positivity, the node negative arm was greater in the cross arm. Or zero resection rate was also greater in the cross arm, and the PCR rate 16% versus 5% greater in the cross combination chemoradiation arm, and a major pathological response, which is a combination of tumor regression grade 1 and 2, so less than 10% vital residual cells left, or no tumor in the primary specimen, 42% versus 12%. So all of those were highly significant, but notwithstanding, they did not impact on the overall survival at 3 years. So the key points about the trial, and obviously there's be further analysis. The trial is closed to recruitment. There will be a further analysis when the last patient is 18 months minimum in follow-up, and then it'll be put together for a publication, maybe at the end of this year, early next year. But what we can say, and this isn't going to change, that the overall survival is equivalent to 3 years, then hence clinical equipoise can be applied in terms of MDT decision-making. There is no winner. Cross was markedly superior in proxy margins of local regional impact, and obviously the patterns of failure data will be of interest when it's further analyzed at the completion of the analysis of the study. But maybe it just reflects the fact that our surgery is a little bit better, and we do a good en-bloc resection, and that sort of benefit reflected in these proxy markers is negated by the fact that it's all removed anyway from the primary site and its surrounds. And also, important point, and again, our original point is with modern radiation therapy and quality assurance, no evidence at all that preoperative radiation therapy significantly increased operative mortality or major respiratory morbidity. Conversely, cross is much easier to tolerate and complete because it's completely a preoperative regimen. And no matter what way you argue and discuss this point, patients hate having post-operative chemotherapy, and in truth, very many of them just cannot tolerate at all. And in that context, quality of life data is going to be very important, again, as part of the secondary endpoints. So just a few other things. There's a really good trial that'll be published about a year after ours, I think, which is ESOPEC, which compares FLOT exactly with cross, exactly the same inclusion criteria as the NeoAegis trial. That's a uniquely German study, and there's other trials that are going out there. And then the final point I want to make is that all of this has been put into a kind of a different context completely now with the trial publication last year from Ronan Kelly, an RCSI graduate and colleagues with Checkmate 577 trial, which showed that giving post-operative adjuvant immune checkpoint inhibitors, nivolumab, which is an anti-PD-1 inhibitor, to patients who had chemoradiation therapy prior to surgery, and then had a resection, and they did not have a complete pathological response, so had residual disease. And those patients were randomized to nivolumab or placebo in a 2-to-1, and we looked at all these sort of points. And a very early follow-up publication, published very quickly in the New England Journal of Medicine, showed that disease-free survival was double in the adjuvant nivolumab arm, so that adjuvant nivolumab is now FDA approved and is really evidence-based, if you like, to be used in the context of multimodal therapies, so preoperative chemoradiation therapy and residual disease in that sort of session. And whether it defines a new standard of care, time will tell, because there's a lot of other trials. There's a lot of other trials out there that are looking at agents like this in the preoperative context, such as Keynote 585 and the Matterhorn trial. So, in conclusion, I hope I've caught up some time. Do we have a standard of care in 2022? Well, not really. There's no single standard. We're going to have our trial, the ESOPEC trial, other trials that will report over the next number of years, and a whole load of trials looking for that role for immune checkpoint inhibitors in the neoadjuvant as well as adjuvant setting. So this is very, very fluid, and it will change. But arguably, adjuvant nivolumab post-cross regimen is the most evidence-based and compelling at this time, based on published or presented literature. So, obvious caveats: the trials do not cover locally advanced disease, CT4A, threatened margin. We're almost certainly going to go with the radiation preference there, and if we have equipoise on this. If a patient has very heavy node positive disease in different compartments, are we more inclined to go with a chemotherapy regimen which has a more likely systemic impact than that, and so on and so forth. There's a lot of these areas that trials will not tell us, but obviously the trials that are out there with well over 1,000 patients between them all will inform us quite a bit over the next number of years. So I'm going to leave it at that. Thank you very, very much for your attention. Thank you.
So, John, I'm not sure if we've run out of time altogether or not.
No, we have. Well, what time is it?
It is.
I think we have actually. So no questions, definitely. Emma had given us permission to go on to about 12:55. So no questions really. Well, just thank everybody.
Yeah, and thank you very much, John.
Pleasure.
And Marco and George.